Welcome back to part 2 of our masterclass. Today, our goal is highly specific and honestly pretty fascinating. We're mapping the clinical pathophysiology and vascular territories of the heart directly to accurate ICD-10-CM codes. Because as clinical documentation integrity specialists, you know you don't just write down numbers, right? You are literally decoding a patient's exact vascular anatomy. Let's get right into it. Here's our clinical to coding pipeline for this explainer. We'll quickly hit clinical foundations, map out ischemic heart disease categories, look at classifying MI types, dive into subsequent MI guidelines, and finally, test our skills with some real-world coding case studies. Kicking things off with Section 1, Clinical Foundations, specifically the anatomy of the heart. Think about the vascular network that keeps the heart pumping. You've got the left main coronary artery branching into the left anterior descending, or the LAD. This includes those absolutely critical diagonal branches D1 and D2 that feed the anterior wall. Then wrapping laterally, we have the circumflex artery, which gives rise to the marginal branches M1 and M2. Over on the right side, the right coronary artery, along with the posterior descending artery and right marginal artery, is doing the heavy lifting to supply the inferior and posterior walls. So why does this matter for us? Well, when you're reading a cath report, you absolutely must recognize these specific culprit vessels to map out the exact topography of the infarct. It's like reading a map, where X marks the spot. And when one of those specific vessels we just talked about, say a diagonal branch of the LAD, completely occludes, what happens? Myocardial infarction. We're talking about irreversible cell death, literally necrosis, caused by prolonged ischemia. And the exact topographical location of this dead tissue, that is the exact bullseye we are trying to hit with our codes. Moving into Section 2, Ischemic heart disease, specifically covering categories I-20 through I-25. It really helps to mentally map out the entire ischemic heart disease neighborhood, so to speak. These conditions live in categories I-20 through I-25. So it starts with I-20 for angina pectoris, then moves into I-21 for an acute myocardial infarction, and I-22 for a subsequent MI. Then we've got I-23 for current complications following an MI, I-24 for other acute ischemic heart diseases, and finally I-25 for chronic conditions like atherosclerosis. Having this sequence locked in your head helps you quickly navigate the codebook based on the exact timeline of the patient's disease and that specific vascular territory we just mapped out. Next up, Section 3, Classifying MI Types, focusing on PCI and CABG types. We're actually going to bypass the standard Type 1 and Type 2 MIs for just a minute and look really closely at Type 4. So, Type 4 MIs happen specifically in the context of a percutaneous coronary intervention, or a PCI. And there are 3 critical subclasses you need to know here. Type 4A is an infarction related to the PCI procedure itself. Type 4B is related to stent thrombosis, which just means a blood clot formed right in the stent. And then Type 4C is an MI caused by restenosis of 50% or greater after an initially successful PCI. Bottom line, if a patient comes in with a blocked stent, you are dealing with a Type 4 MI for sure. Let's juxtapose that Type 4 with Type 5 MIs. While Type 4 is all about PCIs and stents, a Type 5 MI is strictly related to CABG surgery, coronary artery bypass grafting. Now, for a Type 5 MI, you're going to use the specific code I21.9. But, and this is an absolutely crucial point, if the Type 4 or Type 5 MI is post-procedural following cardiac surgery, coding guidelines require you to assign code I97.190 first. That indicates other post-procedural cardiac functional disturbances following cardiac surgery, and you have to sequence that before you code the MI itself. Sequencing is literally everything here. All right, Section 4, Subsequent MI Guidelines, and the infamous 4-week rule. The golden rule in this territory is the 4-week rule. If a patient suffers a new, subsequent acute MI within 4 weeks of the initial acute MI, you must use a code from category I-22. But wait for it, an I-22 code cannot stand alone. It absolutely must be accompanied by an I-21 code to identify the site of that original, initial acute MI. Pairing them up like this proves the patient is still within that critical 4-week healing time frame. Now, the sequencing, meaning which one goes first, depends entirely on whether the subsequent MI caused the admission or if it happened while the patient was already hospitalized. Let's put this into practice with Section 5, Coding Case Studies. Time for some real-world scenarios. Okay, here's your first case study. Let's say a patient is admitted with a STEMI involving the left main coronary artery. They have no history of previous infarction. A week later, while still in the hospital for this initial event, they experience a brand new acute anterolateral STEMI. So think about that 4-week rule we just covered and our vascular map. Which code is going to be the principal diagnosis here, and which is secondary? Take a second to think about it.
All right, let's reveal the answer. The principal diagnosis is I-21.01 for the initial STEMI involving the left main coronary artery. Why? Because that was the primary reason for this hospital admission. Then your secondary diagnosis is I-22.0 for the subsequent STEMI of the anterior wall. Since this new infarction happened while they were already admitted for the first one, the original I-21 code keeps its top spot. Make sense?
Let's level up to a slightly more complex tracking scenario. Imagine a patient is admitted to community hospital with an acute anterolateral wall STEMI. 2 days later, they transfer to University Hospital for an angioplasty. 3 days after that, they return to community hospital to finish their recovery for 4 more days. So we've got 3 separate facility admissions. What is the code for each of these 3 admissions? The answer is actually really fascinating. It's I-21.09 across the board for the first admission to community, the transfer to university, and the transfer back to community. The principal diagnosis remains exactly the same, I-21.09, which is a STEMI involving other coronary artery of the anterior wall. Now, you might be wondering why. Well, because despite moving between physical buildings, this entire journey is considered a single continuous episode of care for that initial infarction.
Now, let's throw a final twist into that scenario. Our patient is finally discharged and goes home. But a week later, they are readmitted to community hospital because they're experiencing severe chest pain. The diagnosis this time is a brand new inferior wall MI, which is likely pointing to an occlusion in the right coronary artery system based on our anatomy review. So how do we code this new admission, knowing we're still well within the 4-week window of the original anterior wall MI?
Here is your final coding sequence. The principal diagnosis flips. It is now I-22.1 for the subsequent STEMI of the inferior wall. Why the swap? Because this specific, new infarction is the exact reason for this new admission. But remember our golden rule? I-22 cannot stand alone. So our secondary diagnosis is I-21.09 to make sure we capture the initial anterolateral STEMI that occurred just a few weeks prior.
And that brings us to the end of this explainer. You've seen firsthand how identifying specific vascular branches from the left anterior descending to the right marginal artery directly dictates your code selection and how the clinical timeline completely alters your sequencing. By mastering these rules, you ensure the patient's true clinical story is documented with absolute precision. So what other intricate clinical stories are you now equipped to accurately decode? Keep learning, keep questioning, and as always, decode healthcare with Arterial.